Welcome to today's episode of the AARC Perspectives Podcast. I am Lisa Fuchs, AARC Director of Education, and have been a practicing RRT and educator for more than 20 years. I am joined by Brie Soldano, a cardiac ICU clinical lead at Nemours Children's Hospital, Delaware. Today, we will be discussing pulmonary arterial hypertension, or PAH. What is it and how is it treated? This is the first in a series of podcasts that AARC is producing on PAH with support from our corporate sponsors, Linde and Mallinckrodt. Thanks, Brie, for joining us. To begin, Brie, can you tell us a little bit about how your journey to being an RT began and why you have such an interest in the pulmonary arterial hypertension arena?
Yes, thanks for having me. Like many of us in this profession, I thought I would be a nurse. I volunteered at a local hospital. I did all of the prereqs. My first day volunteering involved dropping my brand new phone in a toilet, watching a patient escape a nurse by throwing his walker quite forcefully at her. And it ended with being invited to assist in perennial care, which, not my cup of tea. I think we can all agree on that. Following that, again, I went to Salisbury University. I did all of the prereqs for nursing, and I found myself at this kind of impasse of where do I go from here? And I believe it was my nursing advisor introduced me to Dr. Inslee, which anybody who's gone through that program knows quite well. He is a force of nature. And he walked me through what this profession is, what it does, why it's important, why it matters. And he was such an inspiration to me. I made it through their program, graduated, moved to Phoenix, Arizona because adventure. I began my career at Banner Thunderbird, where I had my first NICU pulmonary hypertension baby. And it dawned on me during the care of this patient just how important it is to know when your patient has pulmonary hypertension and what to do. Because like any baby with pulmonary hypertension, she could change her color rapidly, terrifyingly, sats in the 20s. And you would bag with 100% oxygen and nothing would happen. You had to be patient, and I didn't know that. So to categorize myself as terrified would be generous, I think. I don't think I handled it well, but my preceptor was amazing and walked me through it. And she was okay. Disclaimer, the patient was fine. And from there, my career has kind of grown. I went to Hershey Medical Center, where I worked across all of their critical care units in the Children's Hospital. Lots of pulmonary hypertension happening there. It's a level 4 NICU. And now I work here at Nemours. Again, a level 4 NICU. The cardiac center is well known. They have a fantastic program, and I've really enjoyed working here, learning with all these wonderful people. Our cardiologists are absolutely brilliant. And again, pulmonary arterial hypertension is kind of paramount in this unit, and I'm one of the first lines of defense in treating that, especially when they go into crisis mode. So,
as a respiratory therapist, to be involved in the front line, and with that, what is PAH and what types of patients are most often affected?
So the definition of pulmonary hypertension is a mean pulmonary artery pressure exceeding 20 millimeters of mercury and or a pulmonary vascular resistance greater than or equal to 3 Wood units. Kind of depends on what side of the heart is failing for what you're going to use. But that pulmonary arterial pressure is usually the marker. In my world, patients that are most often affected are persistent pulmonary hypertension of the newborn, because we do get newborns in the cardiac unit, because they also come with cardiac defects a lot of the time. And for me, a lot of it's pulmonary hypertension due to left heart failure and just pulmonary arterial hypertension. Again, it's usually directly linked to congenital heart defects. A lot of trisomy 18s, a lot of VSDs, that kind of patient population is primarily what I deal with.
How do you diagnose this?
Well, thankfully, I'm not in charge of diagnosing it, but it is diagnosed formally with cardiac catheterization. However, signs that we look for to be like, could be a pulmonary arterial hypertension patient would be cyanosis or blueness, low oxygen saturations that don't respond to oxygen. Again, because this is a blood flow driven issue, not necessarily oxygen deprivation. Tachycardia, fast heart rate, again, a number one sign of hypoxia. Tachypnea or fast and or labored breathing. And again, especially in children, that's the number one way they try to compensate for the lack of oxygen traveling systemically. But thankfully, I don't have to cardiac cath anybody.
So, what role does a RT play in that interdisciplinary care of the patient?
So first and foremost is awareness. Pulmonary hypertension patient, the first things we're going to know to do in a crisis is to give them 100% oxygen, which is not the norm across the CICU and or the NICU, and also to have nitric at the ready. In our cardiac center, we keep it front and center. It is right where I sit because when we need it yesterday. I usually have it somewhat pre-dressed so I can just throw it in line and get it running because it is the fastest and most direct treatment for a pulmonary hypertension crisis. So I would say knowing to give them oxygen because it's, again, not the norm here in the cardiac center, knowing nitric and knowing it well, and just having the awareness really is the biggest thing because a lot of our kids aren't supposed to have a lot of oxygen. It's a little bit of a confusing factor when you're like, this one's supposed to get 100% when I push this button. Yes, they are.
Is ROP addressed with this high oxygen
Yes.
use?
So we really see that in the NICU a lot. Thankfully, we are not getting a ton of newborns in the cardiac center. It's not a completely foreign concept, but in NICU, it becomes this weighing of, is ROP going to be worse than having a pulmonary hypertension crisis? So we give them what we need, what they need, and we try to limit it. So once their SATs are acceptable, backing off on the oxygen as quickly as we can is definitely one strategy for combating retinopathy of prematurity. But sometimes it's like, you know what, we can do laser eye surgery. It's not the best or the most favorable outcome, but it certainly beats coding a patient when we're weighing big picture
Right.
items. It's like, you know what, I'll take that chance, I guess.
So, is there any other treatment involved? Maybe not from the RT, but in general, how do they treat these babies?
Well, so depending on how it's driven in the unit for us, they can be on diuretics like Lasix. Again, we're doing a fluid balance because this is a very big plumbing issue. They can get cardiac surgery. Honestly, repairing a lot of these kids are VSD kids, and the right heart circuit, the pulmonary circuit, is lower resistance. A lot of the blood chooses to go there. Sometimes it floods the pulmonary circuit. We have pulmonary hypertension due to too much blood, and then that blood isn't going
Mhm.
systemically. So they desat on the pulse ox on one side of their body and not the other, depending on where the shunt is. And you have to balance that. So sometimes we do pulmonary artery banding, sometimes it's a VSD repair. The pulmonary artery band seems counterintuitive. Why would I restrict something that can go into a pulmonary hypertensive crisis? And the answer to that is, again, balancing that blood flow. So you'll get a PA band on a pulmonary hypertension baby and be like, well, this is really bizarre. You have to work around it to the best of your ability. And they do. If they need 100%, you're going to give it to them and you're going to try your best not to flood the pulmonary circuit. But they are very, very tricky patients. And they're those kids that are like drop of a hat. You go into your day like, please, 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 please behave for me
Yeah.
today. I love you. But if that's what it takes, I'll do it. Keeping them calm,
Fine one minute.
all the
Yeah,
things. I'll do anything.
they're fine 1 minute and could rapidly deteriorate in the next, right?
And that's what makes them so scary.
So, what types of education we can't educate a small baby, right? But we have those parents that are very nervous. They may be new parents about their baby and everything that's going on. How do you educate the parents or the caregiver of a baby with PAH as an RT?
Right. Right. Great distinction because cardiology does a lot of that education. We have, for our cardiac kids, we have diagrams of what their heart defect is. We'll go into detail about what those defects mean for this kid. And if it's pulmonary hypertension is part of it, they're usually going to go home on oxygen. They'll also usually go home on sildenafil, which is a common drug that treats pulmonary hypertension. And sometimes they go home with Lasix. So nursing and RT work together to kind of balance out, these are the drugs you're going to give, this is the therapy you're going to have at home. So a lot of my pulmonary hypertension patients require education on O2 therapy. Here's a nasal cannula, goes on this way. Here's an oxygen tank. This is when you're going to use it. Oxygen concentrators are becoming more common at home as well. The most recent one I had went home on CPAP. So we did a lot of education on here's the interface, here's the device, this is how it works, put it together, take it apart, your battery life, things to look out for. So again, those signs of cyanosis, low sats, tachycardia, tachypnea, labored breathing, and these buddies do come back. And I like to think that part of it is because we've done the education with the families. This is the sign that we're going downhill. Please come back. And they don't play around. Most of our families are like, yep, we came back. They were doing a weird thing. And sometimes they're fine, and I love it. And sometimes they're not. So we recently had a pulmonary hypertension baby who also had severe MAPCOs, which is just weird pulmonary circuitry happening. And transport maybe didn't appreciate how bad his pulmonary hypertension could get. So it seemed, maybe a little bit of an assumption, it seemed that he had screamed the entire way to the hospital. And by the time he got to us, he was in crisis. He was grayish, he was bluish. We threw on oxygen, we threw on nitric. We ended up having to intubate because he was just spiraling out of control. So that's another one of the big things is stress for these little kids. They just can't handle it. But back to the root of the question, the education really involves understanding what to look out for and how their home O2 therapy works, and then staying on that regimented drug schedule, whatever it may be.
Do they have any kind of like a care navigator? Just there's a lot of things that they're dealing with, and if they need some answers or help, do they have any kind of support?
Yes, usually. So all of our patients and their families get a care coordinator who will walk them through all the things. They also help coordinate us, the caregivers, on giving them education. They do, if they're going home with devices or meds that they're not maybe accustomed to, we also do extensive education. And then we do like pretend you're at home day where they do all of the meds. They take apart and reassemble the ventilator, put together their oxygen tank, demonstrate to me that they can open it and close it and understand how to read if it's empty. And then outside of that, they have home care companies. So we have one that comes into the hospital, brings their home equipment so they can practice while they're still here, and then supports them when they're at home. So they can call them and say like, hey, this thing is happening. What do I do now? And they will walk them through troubleshooting any equipment stuff. As far as the meds go, they can reach out to their care coordinator and with questions, or sometimes they'll even call our cardiology department. We will chat with families at home. But, it really is, it does fall a lot on the family to know their limitations and to be like, I don't think I'm doing this right, or I don't think what's happening is supposed to be happening. And sometimes that divide is really, it's a real challenge. It can be very frustrating for all parties involved. And they have to learn so much. I teach them about the ventilator. Somebody else comes in and teaches them about the ventilator and maybe uses different verbiage. And therein lies another source of confusion. And they'll come back and they're like, I took this thing out of line because it was alarming. And the home care company said I could. And I'm like, please do not.
Please don't do that.
Please do not do that.
Yeah. So what is the prognosis then for patients who develop PAH?
So pulmonary arterial hypertension, just as its own subcategory, it really depends on the severity. There's such a range. So you can go home and live for years just maintaining on your Lasix, sildenafil, whatever it may be, but it is progressive. So over time, you'll probably add oxygen. Then you might add CPAP. Then you might add another drug. If you're older and you have late onset pulmonary arterial hypertension, the risk of morbidity goes up, right? I mean, that's also kind of how aging works, lucky us. But it does increase the risk of morbidity during any kind of procedure or stressful anything. It gives that right heart pulmonary circuit a very fine line to walk for the rest of your life. So intubations get very scary. Surgeries get very scary. That being said, early diagnosis is key. You can do a lot if you know what you're dealing with. Some people just don't. And obviously staying on top of what you're prescribed. Some people are like, well, I feel better, I'm going to stop taking it. And that's never the answer.
From what you've said, early diagnosis really is multiple eyes and interprofessional education. You as an RT, as trying to apply oxygen that's not working. And it sounds like it's multiple eyes, but you as a frontline RT, you can put the pieces together and collaborate with the physicians, the nurses. So What new research is on the horizon, and does respiratory therapy have a part in that research?
So to my knowledge, WHO has extensive research. Lucky for me, I'm not super familiar with it. I've been working here at Nemours with a multidisciplinary team that we've kind of patched together from nursing, RT, cardiology, cardiac intensivists, and a couple of, I think we have a social worker on that group as well. And it's really just working to captain pulmonary hypertension pathways so that we know a patient has pulmonary hypertension, and we can all, as a team, react and treat these patients as quickly as they need to be treated. Because again, there can be a lot of ignorance there. Somebody shows up, they're like, great, I'm going to bag this patient. And if it's not working, sometimes they move straight to intubation, but sometimes all you have to do is add nitric or increase your FiO2 because in the cardiac center and in NICU, every resuscitation bag is on a blender with a changeable FiO2, and that can make all the difference in the world. So we've all been kind of educating each other. I've been learning a ton. A lot of the diagrams are maybe over my head, but it's so fascinating and it's so amazing to hear these people talk and really just try to pick up as much as you can as you roll along. This profession we're in everything. RTs have all the tea all the time in every hospital. So, just to have the opportunity to pick up even more expertise is huge. And we're hoping to build pathways so that people don't have to question, what do I do next? Call the attending. The attending's not answering. You have something to follow to get that kid back to where they need to be.
Yeah, that's one thing I think in respiratory therapy, I would say as a profession, would you agree that we're continuous learners? And if we don't know something, we're always ready to step in and learn it.
I certainly like to think so. I've had the honor of training a lot of newer RTs to this unit, and they've all been exceptional. I get a lot of questions, and then sometimes I don't know the answer. And we get to find it together. But and that's the other thing working with this team is I have not run into a single situation where somebody was like, wow, you must be really stupid. Everybody's been very gracious. Learning to read echoes, didn't think that would happen in this lifetime or the next, but here I am trying to differentiate a PDA from an aorta, which is maybe a mark of how smart I might be. But I love this profession for that. And I've met a lot of really amazing and interesting people who are all just very driven to do the best by their patients. And I think that's just so cool.
Well, Brie, I want to thank you for joining us today for this episode of the AARC Perspectives Podcast. As a member, be sure to subscribe to the AARC Perspectives whenever you download or listen to your podcasts, and keep an eye on your inbox for additional episodes on PAH coming later this year. You can also visit aarc.org and search for pulmonary artery hypertension for additional resources. The AARC thanks Linde and Mallinckrodt for their support of this podcast series.